Guys.
Perfect. Thank you so much for joining. We appreciate your support.
Hi.
Perfect. Nancy, was that you?
Nope.
Let's see.
Hi, my name is Sarah Kelly.
Perfect. Thank you for joining.
Thank you. I'm on Sarah's inpatient team.
One of our oncology physician assistants.
Awesome. Perfect. Thank you so much for joining. I appreciate it.
Thank you.
Who else am I missing? Zell,
Yes.
would you mind doing a short introduction?
Sure. Hi, my name is Zell, and I am one of the nurse managers at Miami Cancer Institute. And so I consider myself a liaison between our call center where we have nurses and schedulers and kind of bridging those gaps between the building and the providers and making sure the patients get seen with the right doctor right away.
Perfect. Thank you so much for joining.
Thank you.
Cecilia? Who else hasn't gone? Cecilia, if you can hear us and you want to do a short introduction?
Hi. Actually, I'm a former presenter. I was there like a few months ago, and I wanna admire my friend and colleague Dr. Joseph's presentation today.
Perfect. Thank you so much. I realized I'm looking at your last name and I'm like, I know.
It sounds familiar, right?
That's so funny. Thank you so much. We appreciate your support and coming on.
No problem. My pleasure.
And Kathy?
Hi, I'm Kathy Baker, and I am the founder of the BRCA1 mutation and have had both breast cancer and ovarian cancer.
Perfect. Thank you so much for joining. And did we catch everybody on the call?
Hi, I'm Christine. I'd like to show myself, but I can't maneuver this camera.
It's, you know what, if you hit on the bottom left corner, it should say video.
Yes, but unfortunately it's telling me to do something in my settings, so I haven't figured that one out yet.
No problem.
But I could hear everybody, and obviously you can hear me.
Yeah. Thank you so much for coming on. Thank you so much for coming on. Sorry.
It's
I'm gonna
okay.
allow one more person in the room, and then what I'm going to do is I'm going to mute everybody, and we're going to go ahead and get started, as we appreciate Dr. Joseph coming on and her time after she's had a long day, I'm sure, with her patients and taking care of women like us in the community.
Hi, Dr. Kalman.
Let's see. What I will do is mute everybody, and we're going to go ahead and get started.
No problem. All right, we'll do. Thanks, everybody. All righty, are we ready?
Perfect. So good evening, everybody. I'm Tracy Milgram-Posner. I'm the founder of BRCA Strong, where we inspire, empower, educate, navigate, and support survivors, and thrivers to eliminate the feeling of isolation and help you feel whole again. During COVID-19, we are sending out packages to support women who are going in for surgery, who are diagnosed, and who have family members or friends that need support. We're always here to help you. If you don't follow us on Instagram, please take the time to go ahead and follow us on Instagram, where we post all of our programs, as we specialize with 2 physicians every week to educate the community, especially during COVID-19. You know, I think it's so imperative that we know our options and know our physicians. So thank you so much for joining us. I'd like to welcome Dr. Sarah Joseph.
You're on mute, doctor.
Oop, hold on one sec. Let's see. Hold on one sec. We can't hear you.
Better?
There you go.
Was I talking to an empty audience? Okay, I just wanted to say thanks to you for being such a good community leader when it comes to this, and really putting up, you know, the whole organization for this lecture series, and to the audience for coming and showing support as well. So let me introduce myself. My name is Sarah Joseph. My specialty is medical oncology, more specifically gastrointestinal cancers. So a little bit more about who I am. I did let me change slides. There we go. I did a bachelor's and master's in Montreal, McGill University. I did my medical school at St. George's University. I did my internal medicine residency in Pennsylvania. And then afterwards, for my fellowship for hematology oncology, I did it both in Pennsylvania and then 2 years back home in Montreal. So I started Miami Cancer Institute about a year ago. So that's a little bit about me. Today's itinerary, we're going to define what exactly are BRCA-associated gastrointestinal cancers. So we're going to highlight pancreatic, we're going to highlight colorectal cancers, and we're going to see the risks and the management with that. In addition to that, we're going to go over screenings for the general public and how that changes when we are carriers for this breast cancer gene, okay? So what are gastrointestinal cancers? It's a term that's very broadly used to really define cancers that start from the esophagus and go all the way up to the anus. So it encompasses the pancreas, it encompasses small intestine, stomach, bile duct, the esophagus, the liver, and the colon. Okay, so it really is a broad term. So when I say GI cancers, I'm really referring to this broad topic of cancers and malignancies. So a little stats for gastrointestinal cancers. It is collectively the #1 most common type of cancer that we have, and it is the second leading cause of death. There has been an increase in incidence of these cancers, and many would say that's attributed because of the increase in screening that we have, which I'll get into a little bit later on in the talk. So globally, in a year, about 4.5 million patients die from this. And it's about 3.6 times patients die from this more in GI cancers than in breast. So this is why it's very important for us to dive in to see how BRCA1 and 2 carriers would be affected and how we can prevent this from happening. So BRCA 1 and 2, it is an autosomal dominant type of inheritance pattern, okay? So it is generational. It is a known fact that we are more susceptible to breast and to ovarian cancers. But what about other types of cancers? Which I'm so blessed that Tracy invited me to speak about this today. So we're going to focus on GI, so predominantly pancreatic. And what I'm going to get into is colorectal. So how do we figure out that pancreatic cancers are more linked to BRCA1 and 2 mutation carriers? So it is a breast cancer linkage consortium that reported this. So if you are a carrier of the BRCA1 gene mutation, you're twice as likely to develop pancreatic cancer in relation to the general public. If it's a BRCA2 mutation, it's on average 3.5 times more likely. There are 2 studies that really looked into this. Both were published in the National Cancer Institute. So the one that really defined our BRCA1 mutation carriers was done in 2002. They looked at about 12,000 patients, and that encompassed about 700 families across North America and Europe. And what they ended up finding was when they looked at a cohort study, that is what we saw in both male and female that carry this mutation, that there is an increased risk, okay? The same type of study design was done when looked at BRCA2 mutation carriers. So there was the same breast cancer linkage consortium, again, published in the Journal of National Cancer Institute. And that was actually, coming to think of it, is a really long time ago, 1999. So they looked at about 200, I would say 175 families with breast cancer and ovarian cancers with the BRCA2 mutation across North America and across Europe. And what we found was that pancreatic cancer was at an elevated risk of about 3.5 times the general public. So how does that translate in the overall risk for these patient populations? It's about 1 to 5% increase of pancreatic cancers in BRCA1 and BRCA2 respectively. So BRCA2 mutation carriers have a little bit more of an elevated risk for developing pancreatic cancer than BRCA1 and in relation to the general public. So when do we tend to see patients develop pancreatic cancers in BRCA2 mutation? On average, when they looked at studies, it was around 50s, as late as 60s. So the median average age was in the late 50s. So let's go in and dive into a little bit more about what pancreatic cancer is. What are the signs? What are the symptoms? How do you know if you're at home? Should you be worried? Should you get screened? Is there anything out there for you to do? So we're going to touch upon the anatomy, the risk factors, the symptoms, treatment, and kind of the screening that goes along with that as well. So this is the pancreas. It's highlighted in kind of like a neon orange. It spans across the abdomen. A lot of the times we know the pancreas as having patients that are affected with diabetes. So this I actually got from a diabetic website that really defined where the anatomy is of the pancreas. So if we look here, this is the pancreas, and it kind of encompasses over the stomach, the small intestine, this is the gallbladder, and this is the liver. And I will go into a little bit more detail as to why the anatomy of the pancreas is important for symptoms when it comes to non-specific symptoms that we don't know what's happening. When we think about the anatomy of the pancreas, it kind of makes sense. So there's different types of pancreatic cancer. What I'm going to focus on today would be adenocarcinoma, which is the more predominant lethal type of cancer that we see in the general public, okay? However, just keep in mind that there are other subtypes of pancreatic cancer. The other ones are a neuroendocrine tumor, which secretes more hormones, a little bit less aggressive depending on the grade of that type of cancer. And if there is a mass in the pancreas, we always will get a biopsy because we don't know if it's an adenocarcinoma, neuroendocrine tumor, and surprisingly, it could be also a lymphoma, which is a blood type of cancer. So pancreatic cancer, it is the fourth leading cause of death when it comes to cancer deaths in general. Risk factors really are if we smoke, we live a very sedentary life that leads to inactivity and subsequent obesity. Symptoms can range from being asymptomatic. Patients go to work, they have their day-to-day, they have no symptoms. They go to the hospital for something completely different, say a cough, and they do a scan and they have an incidental finding on their pancreas. So I'm going to get into that a little bit later on, but why is this important to us? So on average, 150 patients per day are diagnosed with a pancreatic cancer in America. It is one of the most common types of pancreatic cancers is the adenocarcinoma, and there is no standard testing to diagnose for the standard general population. However, with BRCA2 and BRCA1, there are screening criteria, which I'm going to get into. However, what are the risk factors? So family history is a big one. And I think when it comes to talking about genetic predisposition, mutations like BRCA, we know our family history. You know which relatives were diagnosed with ovarian, with breast, with prostate, with male breast cancer, but it's also crucial to know at what age they're diagnosed and if they have pancreatic cancer as well, because that links into when you will be recommended to go screening. The other thing is a diet. We're going to recommend that patients have fresh fruits, vegetables, low in red meat, low in saturated fats. If our diet is good, by consequence, the other risk factor, which is obesity, kind of goes down as well. Because if we eat well and we work out well, then we're naturally going to lose weight, and that will decrease the risk of having obesity as well. Race comes into play where we see Ashkenazi Jews and Africans to be at elevated risk for pancreatic cancer. Smoking, being a male, and just aging also has risk factors for developing this type of cancer. One of the things that the pancreas do with the pancreatic function is secretes hormones. And it also, one of them, the big one, is insulin. So when we have a dysfunction with insulin, we are diagnosed with diabetes. And for us, we just go about our days. We don't really think too much of it. Instead, that, diabetes, we have to lose weight, we have to eat healthy, we'll type to manage it with food and with medications. However, there has been an association of diabetes and the development of pancreatic cancer. The other thing too is whenever we have a chronic inflammation of the pancreas, and that comes with pancreatitis. So titus at the end just means inflammation. So if we drink a lot of alcohol, certain foods that we eat, certain medications that we take can cause what we call a pancreatitis. If we have chronic inflammation of the pancreas, that has also been linked to the development of pancreatic cancer. So how would you know that you have pancreatic cancer? What are the symptoms? It could be nothing. You can really have no symptoms, or you can have unintentional weight loss. So what I mean by that is if you're working out, if you're eating well, you will naturally lose weight. However, if you're doing none of that, you're sitting on the sofa, you're going to work, you're doing your day-to-day, and all of a sudden you realize that your clothes is fitting looser, and you jump on the scale and you lost 50 pounds in 6 months, that is not normal. It's okay. That is a sign that you should go to your primary care physician or your family physician and tell them, I have weight loss and I'm not sure why I have this. The other thing, if you all of a sudden kind of turn yellow, so where the pancreas is located, it's located near the liver, and the liver and the gallbladder are responsible for draining bile. And bile, if there is a backflow and there's an obstruction from a pancreatic mass, we don't metabolize bile. And as a consequence, you become yellow. So your eyes become yellow, your skin becomes yellow, automatically go to the emergency room because there's something that's happening in that area that cries for further attention. Nausea, change in stools, more predominantly, it becomes pale, your stools, and they actually float. When you have a bowel movement, you'll see your stools floating and they're lighter in color. And as we mentioned before, a new recent onset of diabetes can also be linked to the development of pancreatic cancer. So what are the screening protocols for pancreatic cancer? To date, general population, there is none, okay? How about our population that we have here tonight, the BRCA 1 and 2 mutation carriers? There's no consensus about when to start, how often to repeat it. However, we have an international pancreatic screening protocol, and that is based on your family history. So when you speak to your uncle, when you speak to your grandfather, and they have a diagnosis of pancreatic cancer, ask them what age. If they were diagnosed at age 50, that's important for you. And I will get into that on the next slide. So again, first degree relatives, meaning parents, brothers, sisters diagnosed with pancreatic cancer. In addition to that, any patient that has 2 family members, it doesn't have to be first degree, but in your family lineage, if you have 2 family members that have been diagnosed with pancreatic cancer, ask them and be very thorough with your family history and ask them at what age. So it begins 10 years than the youngest family member that was diagnosed with pancreatic cancer. So if your uncle was diagnosed at age 50, then we recommend that you be screened 10 years younger, so at age 40. How do we screen for pancreatic cancer? Do we just do an X-ray? Do we do an ultrasound? What do we do? The most sensitive test that we can provide is an MRI of the abdomen. The other test that actually can do an ultrasound, and we do an endoscope, which means we put the camera down the esophagus, into the stomach, into the small intestine, and then we have an ultrasound that we look with a probe that can actually take biopsies if we see anything suspicious, is called an endoscopic ultrasound. In other words, an EUS, it's just an abbreviation. So this is what an MRI machine looks like. A lot of patients hate it. They will ask for medications to relax them. I personally hate an MRI machine. You get very claustrophobic, so I totally get it. But this is what it looks like. And this is the endoscopic ultrasound. So as we can see, this is where the scope, it goes through the mouth, into the esophagus, into the stomach, and then it goes into the small intestine, and it actually can visualize if there's anything that is suspicious with the pancreas, okay? You won't feel a thing when this happens. We give a lot of numbing medications. It's not me that does it. You don't want me doing it, but it would be a select group of what we call gastrointestinal physicians that do it. So the next slide is kind of busy, but I put really pertinent information. So who gets screened? If you have a BRCA 2 and a BRCA 1 mutation with at least one affected first degree blood relative or 2 relatives in your family. So that's the population that gets screened with this carrier mutation. At what age do we start screening? So if you don't have any family history, say you're adopted, you don't really know, then we recommend you to start screening at age 45 or 50. If you know the age of onset of pancreatic cancer in your family, then it's 10 years younger than their age of diagnosis, okay? How do we screen? An MRI is very sensitive, and an endoscopic ultrasound. The other thing that is also recommended is a fasting blood glucose to see if you have a new diagnosis of diabetes as well. What's a little bit iffy on these guidelines is when do we do an MRI? When do we do an EUS? How often do we do it? Do we do it every year, every 6 months, every 2 years? There's no consensus, and that's still an area of further investigation, okay? But just know that there are screening guidelines for BRCA1 and 2 mutation carriers, but not for the general public when it comes to pancreatic cancers. So treatment, I'm going to touch on this really briefly. The treatment for pancreatic cancer, when it comes in comparison to the general population, there's nothing different to date. If the cancer is localized to the pancreas, then it's a surgical resection, because that is the only hope that we can offer a cure. The minute that there are lesions and cancer cells that have left the pancreas and have spread to different areas of the body, we term that metastatic or a stage 4, locally advanced. That means that it has spread to the liver, for example. So we cannot resect the pancreas at that time to offer a cure. So at that time, chemotherapy is the mainstay treatment. There are studies. One of the biggest clinical trials to date is called the POLO trial, that has looked at giving chemotherapy up front for cancer patients with pancreatic cancer. And if you do test positive for BRCA1 or 2, then the same medication that has been studied extensively in ovarian, for example, the PARP inhibitors, olaparib, then we stop the chemotherapy and we put them on maintenance PARP inhibitor treatment with no chemotherapy. And that has actually shown to have some very promising data. So again, there's no definitive study. There's no standard of care when it comes to PARP inhibitors, but there are multiple studies that are looking at this right now, okay? So in general, knowing the signs of pancreatic cancer, reducing your risk by eating better, by exercising, by living a very healthy lifestyle, and understanding the risk factors, new onset of diabetes, if you're all of a sudden turn yellow, if you have unexplained weight loss, these are the signs that you need to then go get help.
Okay, I found this.
Sorry, that was Siri. Again, screening criteria for BRCA1 and 2, 10 years younger than the age of onset than a family member, or at age 45 or 50. How do we do that? An MRI or an endoscopic ultrasound? And there is no consensus of how to alternate that. So what I would recommend is if you start off with an MRI, then in the next year get an EUS, and you can alternate that way. It's kind of like alternating mammograms and breast MRIs that we naturally do. So what about the next type of cancers? So colon cancers are a hot topic, I think right now, and there is no conclusive, consistent data for BRCA1 and 2. There are studies that show an elevated risk for BRCA1 mutation carriers. Again, there is no standard of care. But the reason that I wanted to bring this up today is because we save a lot of lives with screening when it comes to colon cancer, and to bring this awareness to our general population. So colorectal cancer, we'll talk about the incidence, risk factors, symptoms, diagnosis, treatment. We'll touch briefly upon all of this. But this is just a schematic of what it is. So it starts at the cecum, which is down here, the ascending colon, so it kind of goes up, the transverse colon goes across, descending goes down, sigmoid, and then finally the rectum, and then stools. Over here is a colon cancer that we have noted during a colonoscopy. So a colonoscopy is a camera that really goes through and it looks through all of the colon to see if there's any polyps, any adenomas, any masses that look abnormal. And then at that point during the colonoscopy, they can take biopsies. And it's through a biopsy that we can tell if something is malignant or if something is not, meaning it's benign. So this is just looking at what a CT scan can show us. So this is the colon, the white is healthy, 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 and then you see it gets a little bit darker. This is what the mass is. So this is what a colon cancer looks like when we do a colonoscopy, okay? So this is the scan, and this is the colonoscopy. So what is the incidence of colorectal cancer in the world? About 1.8 million new cases a year, and that accounts for about 900,000 deaths. So in the US alone, that's about 50,000 patients that die of this. And there's risk factors that we can modify. Very similar to pancreatic cancer, the risk factors are age, your history. So family history plays a huge role, because besides BRCA1 and 2, we have other types of genetic conditions that also predispose you to colorectal cancer, like Lynch syndrome, for example. Smoking has been linked to colorectal cancer. A poor diet high in red meat, for example, has been linked. Too much alcohol, and just being a couch potato. So these are all modifiable risk factors that we can do to decrease our risk of developing colorectal cancer. So what are the symptoms? It's a little bit different than pancreatic cancer. So if you're diagnosed, or you do blood work, just routine blood work at your primary care physician, and they go, you know what, you are actually iron deficiency, you are anemic, and they put you on iron pills. I think as a patient, it's always crucial that we take charge of our health. So it's never okay to just go on a medication. I always ask why. Why am I anemic? Is it celiac disease? Am I losing blood through my menses? Why am I iron deficient? If you are over the age of 50 and you are diagnosed with iron deficiency anemia, get a colonoscopy. It is colorectal cancer unless proven otherwise. So we always have to look for the cause of the iron deficiency anemia. So if you have blood in your stools, meaning if it's dark, if, for example, your stools are always a normal brown, and then you're looking and it's dark, that's a sign that there's blood in your stool. If you have a change in the shape, if they're pencil thin, your stools all of a sudden, if they're changing consistency and you didn't change your diet, you didn't change your lifestyle, there's no reason for it, then that's always something to keep on your radar. The other thing would be the unattended weight loss, the change in bowel movements, cramping, decrease in appetite. But I think the major ones are the change in your caliber of stools and the anemia, iron deficiency anemia. So how do we screen for colorectal cancer? The general consensus is age 50. However, there are certain race groups like African Americans that are at elevated risk of developing cancer. And as we can see, a lot of these patients are diagnosed before the age of 45. So the US Preventative Task Force, the American Cancer Society, depending on your race, will then identify you to get screening at age 45. A lot of the times we don't promote screening. And I think it's our due diligence as not only medical oncologists, but as friends, as colleagues, as general providers, that if you're over the age of 50, to not only be screened for colorectal cancer, but to go ahead and get your pap smear, to go ahead and get your mammograms, because these are ways that we can prevent cancer, or we can catch them at an early stage and actually provide a cure. So this is a pretty busy schematic, but I kind of like it because it kind of goes, really, you kind of follow it. So are you over the age of 50? Yes. Have you been screened for colon cancer? Great. Now tell others to go ahead and get screened. Literally, it's advocating that you did the right thing. Now go spread the word. Now, if you're over the age of 50 and that you have not gotten screened, do you know your screening options? So there are different ways to get screened for colon cancer. There's a FIT test where we test your stool for blood. I always tell patients that even if you can do the non-invasive testing for colon cancer, but if any of those tests comes back positive, you need the gold standard, which is a colonoscopy. So I am a big proponent to just go ahead and get your screening colonoscopy. If you're less than age 50 and you have a family history, or you're African American or a different type of minority, then that's when we recommend screening based on your family history and then based on your race. So generally it's around age 45, or if you have a strong family history, Lynch, for example, and BRCA will fit into this eventually when we have more conclusive data, but there is data for BRCA1. It would be just like pancreatic to be screened 10 years younger than the age of onset of your family member. So standard of care for screening is a colonoscopy. It is accurate. You can get a diagnosis, we can get a biopsy, and we can visualize everything during a colonoscopy. So gold standard colonoscopy. And it's so important because we diagnose about 130 cases a year. 1 in 3 general populations have not gone through any type of screening, and it's 100% preventable, and it's 100% curable if we get screened early on. So it's the number one thing that we can do not only for colon cancer, but for breast cancer, for cervical cancer, and for pancreatic cancer when we look at the screening criteria for BRCA 1 and 2. So what do we do for our colon health? We be active, we eat well, we exercise, we spread the word for screening, we know the criteria for screening, know the signs and symptoms of what this could potentially be. So again, the major ones are a change in your stool and for iron deficiency anemia. So I think the two big cancers for BRCA 1 and 2 would be colon, would be pancreatic. And it is a field that is evolving every day with research, evolving every day with how we interact with patients, what type of FDA recommendations we make, screening recommendations. But I think spreading the word, getting the awareness out to the community is the number one way that we can actually prevent this from happening and really get patients screened early on. So I will take some questions, but I just wanted to let you guys know that in November, it's Pancreatic Cancer Awareness Month, and in March, it's for colorectal. Okay, thank you.
Thank you so much. What I'm gonna do is if you wanna pull your screen down for me and then we can open up. Thank you so much for such an informative presentation. So much more information, I think, is available out there. Why we have you come on is because educating the community and knowing your options like colon cancer screenings, preventative measures, we're really just spoken about, when you're given the diagnosis BRCA 1 or BRCA 2, here's your, plastic surgeon, here's your breast surgeon, here's your gyno, but where's all of our other organs that play a role in the BRCA? So I appreciate you coming on tonight. And what I will do is, let's open up for conversation. And what I'm going to ask is if you guys want to raise your hand so we can see who has questions. Or if you have questions, you can unmute yourself or raise your hand. One question I do have, right, is just out of curiosity for BRCA 2, like if there's no pancreatic screening in your, cancer in your family, but there's colon or there's testicular, like, do you have to worry about doing these pancreatic screenings? Like at what age is appropriate for BRCA 2? Like, do we wait until we're 50 just because somebody didn't have it, but our genetics say we obviously have a higher risk?
Correct. There's about, 5% or 3.5 times more risk, but the general consensus, if you don't have a family history, would be around age 45.
Okay, so start screening at age 45.
Again, if you have any symptoms, sooner, but asymptomatic, perfectly fine, age 45.
Perfect. Thank you.
And I have a question. This is Tammy. Great presentation, very thorough and a lot of information. I am BRCA 1 positive and a 2-time ovarian cancer survivor, and I have had family members that have passed away from pancreatic cancer. I have polyps and things like that. Is that and I've had I had one colonoscopy right before I had my hysterectomy, which prompted, all of that. How often, once you start that process, should you continue to do that, especially if you have a history of ovarian cancer? Because I know that often shows up in the colon and other areas.
Sometimes ovarian can present with peritoneal seeding, looks like colon, or colon looks like ovarian. There's really no rhyme and reason.
Right.
One of the nice things about a colonoscopy is when they do the biopsies, we have different grades. So if it's a hyperplastic lesion, if it's an adenoma, if it's a villus lesion, the gastroenterologist at the time when he gets back the pathology report can tell you, you have a hyperplastic polyp, you're at high risk, I'm going to redo a colonoscopy within a year. You have an adenoma, you're not high risk, I'm going to redo it in 5 years. It really depends on the initial findings of your colonoscopy and if they biopsy anything and what that biopsy shows.
Okay. Thank you so much.
I have a question.
Go ahead.
It's Nancy. About colon cancer, unrelated to the BRCA gene. You talked about family history. Are we talking first-degree relatives or further away relatives? For instance, I have a cousin who has had colon cancer.
So there is different criteria. One of them is called the Amsterdam criteria that looks at that, but they mostly will look at first-degree relatives. So first generation. I think a cousin may be too distant, but if it was like a parent or, a sibling that was diagnosed at an early age, then it would be wise to then get tested for Lynch, for example. And then that's when they look at mutational status, look at DNA repair stuff, and then tell you to get screened 10 years earlier than their age of onset.
Thank you.
No problem.
Is there any other questions?
No more questions. Okay.
No more questions? I was thinking the same thing. Well, I really appreciate you coming on tonight and sharing this information, as you and I have spoken on how imperative it is to share all this information and bring it out there. And I know we'll be sharing it all over our group and all over our website and stuff, because the information that you shared with us tonight can help so many women out there. And
I can send you my presentation. If you do remember questions, my email, I'll put it on to, it's sjoseph@baptisthealth.net. Just shoot me an email. Anyone, feel free. I'm pretty good with my emails to respond back.
perfect. Well, thank you so much for coming on and dedicating your time to helping our community and making a difference.
Thank you for organizing this. It was great.
Perfect.
Great. Have a good night. Thanks.
Thank you.
Bye.